Good afternoon, everyone. This is Shagnik from Clarnet. Clarnet is very proud to be a part of this webinar as its digital partner. Now, without further ado, I would like to play a short video of Clarnet. Thank you, everyone, for the patience. As we all know, Clarnet is India's largest live digital CME and doctors generated medical content platform, which is exclusively free for all the medical practitioners. We are very grateful to National Neonatology Forum, Gujarat State Chapter, and the star studded panel with such highly affiliated doctors to be associated with us on our platform. Now, without further delay, I would like to hand over this session to Dr. Prashant Karia. Sir, you may proceed.
Thank you. So, welcome everyone to New Year 2022, in which we are continuing Neonatal Pathshala. It's been said that whenever we do some new things, we usually start with prayers. So, I request Dr. Reshma Pujara to start with the prayers. Dr. Reshma, please.
Yeah. Thank you, Dr. Prashant and Dr. Dipen, for giving me this opportunity. કોઈ પણ સારા કામની શરૂઆત આપણે સરસ્વતી વંદનાથી કરીએ. So let us do this small prayer. Ya kundendu tushar har dhavala ya shubhravastramrita ya वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युत शङ्कर प्रभृतिभिः देवै सदा वन्दिता सा मां पातु सरस्वती भगवती निशेषजाड्यापा निशेषजाड्यापहा. Thank you.
Thank you, Dr. Reshma. Dr. Sandeep Trivedi has here started with Neonatal Pathshala, and Dr. Dipen Patel has continued the same. So I request our President 2023, Dr. Dipen Patel, to welcome the gathering.
Dear colleagues, good afternoon. Thank you, Dr. Prashant Bhai, for introducing. We all know that Neonatal Pathshala is a prestigious academic activity of Gujarat NNF. Dr. Sandeep Trivedi sir and team has successfully completed 1 year of Neonatal Pathshala continuously without any break of a session. We, the team of Gujarat NNF, will continue doing our best to spread the knowledge and wisdom for upliftment of neonatology through continuing this noble work, which is organized every Wednesday, every weekly. We have planned to bring neonatal fellows across our state and our country on the same platform with their coordinators for active participation and representation. We will have one fellow or PG case presentation every month, one seminar, and 2 expert teaching lectures in a month. We will try to make a schedule of 3 months of Neonatal Pathshala. We are in a contact with Gujarat Medical Council representative for getting Gujarat Medical Council credit hours accreditation for this program. Actually, online accreditation has never been done by Gujarat Medical Council, so it is a little bit difficult for them, but still we are working on it to get the Gujarat Medical Council accreditation. We thank Dr. Sandeep Trivedi sir, project in charge Dr. Yogesh Parikh sir, advisor Dr. Somsekhar sir, and Dr. Ashish Mehta sir, and Dr. Prashant Karia for bringing Neonatal Pathshala to the front level of academic activity at national and international level. We thank our digital partner ClearNet and their team for continuous support throughout the journey. We also thank Dr. Kamna Gandhi and Dr. Kiran More sir for accepting the invitation as an expert in the very short time for this first presentation.
Hello.
We lost him, I think.
Yeah, we lost him. So thank you so much, everyone. By the time he comes back, we continue with the introduction of our today's faculty. We are having two experts with us, Dr. Kiran More. He is a good friend of everyone in Gujarat. He was working in Gujarat in Surat. So good friend. He has done his, at present he is HOD Neonatology, Wadia General Hospital. And academically more sound and more active. He is having more than 30 publications, chapters in the books, and called for national and international conferences. So we welcome Dr. Kiran More. We do have Dr. Kamna Gandhi with us. She is a consultant pediatric infectious disease consultant at My Pediacare Infections Clinic, Vasana, Vadodara. She was APA in GMERS Gotri and professor in Parul Institute of Medical Science and Research. She is academically very sound, and we are thankful that Dr. Kamna Gandhi is there with us. Dr. Munjal Kapadia is the Neonatology Fellow at Akanksha Children's Hospital under the guidance of Dr. Biraj Shakkar. He has prepared a case and he is going to present the case. The case discussion will be for around 45 to 50 minutes, in which the Munjal will be presenting a case and the two experts will be asking the questions. So without taking much of a time, I request Munjal to start with the case presentation. Thank you.
Thank you. Thank you, Prashant. And thank you, NNF Gujarat.
Good afternoon, respected faculties.
Hi, good afternoon. Would you like to share the slides? Yeah, perfect.
Good afternoon, everyone.
Am I audible?
Yeah, perfect.
Okay.
Yes.
Son of Parul, first of twins, delivered at gestational age of.
The screen is not sharing.
Not shared, yeah.
Okay, sorry. Screen नहीं आउदी.
Continue.
કરી તો છે કે નહીં થતી. થાય છે જો તો ભાઈ.
It's visible now.
થઈ visible.
Yeah, it's visible, Munjal. Yeah, good.
Okay. Son of Parul, first of twins, delivered at gestational age of 31 plus 5 weeks by LSCS at Akanksha Hospital, Anand, Gujarat, and admitted in NICU of Akanksha Hospital. Antenatal history suggestive of elderly primary gravida mother, age 42 years, with active married life of 9 years, conceived by IVF at Akanksha Hospital, Anand. Pregnancy was achieved after third trial of IVF via donated ovum her husband's sperm. LMP was 21/4/2022 and EDD was 28th of Jan 2023. Regular antenatal checkups and antenatal USG were done. Now about the first trimester, USG was suggestive of twin pregnancy. Mother was screened for HIV, HBsAg and torch titers, and she was negative for the same. During second trimester and third trimester, USG were done, which was suggestive of DCDA twins, that is dichorionic diamniotic twins with bilateral ventriculomegaly in twin 1. Follow-up USG after 2 weeks was suggestive of ventriculomegaly of lateral ventricles with normal gyri and sulci, and Doppler were normal. So torch panel of amniotic fluid by DNA PCR was done, which was suggestive of positive CMV PCR. Karyotyping of the amniotic fluid was also done, which was normal. Mother was given oral acyclovir followed by oral vanganciclovir. She had undergone 3 follow-up antenatal USG, which was suggestive of bilateral borderline ventriculomegaly with normal gyri and sulci. 2 courses of betamethasone 12 mg IM were given at 26 weeks of gestational age and 30 weeks of gestational age.
Munjal, can I just stop you before we're going to the postnatal history? On the antenatal, I would like to know more details about the ventricular megaly and what sort of dimensions usually concerns. Is there a classification based on the diameter of the ventricles, like mild, moderate, severe? You will classify which baby specifically you will. So give more information about the antenatal ventricular megaly.
Yes, sir. We can label it as ventriculomegaly if the diameter is more than 10 mm, and it is classified as 10 to 12 is mild, 12 to 15 is moderate, and more than 15 is severe ventriculomegaly. But in the scanning, it was only written mild ventriculomegaly, and dimension was not mentioned in the USG report of that patient.
Okay, and what do you think is the potential cause in this particular reason for the ventricular megaly in this baby?
It may be the ventriculomegaly may occur due to infection, or if there is any any anatomical defect, which may be due to stenosis, or yes, sir, this two.
Okay, and this was the elderly primary 43-year-old. Any other genetic or other screening, high risk screening was done?
No, other screening were not done. Not done.
Okay. There are some questions for the torch, but I'll leave Dr. Kamna to ask that. We can have the discussion in postnatal course along with the antenatal. So you can continue postnatally. Unless Dr. Kamna, you want to ask something.
No, I wanted to ask that why was the oral acyclovir given before valganciclovir?
Yeah, exactly.
Yes, yes. Actually, I've seen the treatment, and it is written that either you can give high dose acyclovir, and that is 8 gram per kg per day and it may be started after 25 weeks or after 3 weeks of detection of after the infection, after the detection of infection, and it may be continued up to delivery. But here, it was acyclovir was given for 10 days, and after that, valganciclovir was given.
So the drug of the choice for CMV, if at all we want to give the treatment, that is a different topic. That would be valganciclovir, or acyclovir also can be used.
Valganciclovir is the treatment of choice, but
Yes.
we can also give high dose acyclovir. That was what I read.
Yeah, that is only in case if it's not available and we do not have a choice. One more question I wanted to ask you. The mother was torch negative, and baby antepartum diagnosis of CMV was established by doing a CMV PCR on an amniotic fluid.
Yes,
so,
ma'am.
Is it a confirmatory of CMV disease in the baby? Why was it done?
CMV DNA PCR amplifies the DNA material, so it may it may occur that the patient may not have manifestation of disease. Only the virus may be present, so the patient may be asymptomatic. But if there are
But the patient is a baby or mother you are talking about?
No, amniocentesis was done of the baby, and amniocentesis was done of the baby's amniotic sac fluid, and mother's report were done previously at the time of embryo implantation. At that time, torch titer was negative of the mother.
Yeah, so she was seronegative, and now the PCR is positive. So she must have got a primary infection.
Primary infection during after pregnancy.
Correct. Okay, go ahead. We'll discuss it later.
Yeah, just one more question, because now we are stopping you about betamethasone. Suppose somebody is threatened preterm level is received one betamethasone and the pregnancy continued. After how many weeks you will repeat the course, or for how many courses, and whether there's a need to repeat or not? What is the recommendation and what is your practice?
Yes, sir. If the pregnancy is between 24 to 34, 24 weeks to 34 weeks gestational age, we can repeat. And if we are expecting delivery within 7 days, then we can repeat, and we can also give a rescue dose too. But if pregnancy is continuing and we are not sure that it will occur within 7 days or within a week, then we may withhold the giving the second dose.
This is your practice, or is it the recommendation from the Foxy?
Foxy no recommendation 24 to 34 weeks. 2 doses. Sir, I am a little bit confused.
That's okay. I mean, it's a gray zone actually. I mean, there is no, I think, consensus. But yeah, there is no need to keep on repeating the courses once, I mean, it's gone beyond. You are clearly close. Your answer is okay to this thing, because this particular case, I think it was 4 weeks apart. So a lot of time you can say
Yes.
the effect of the first year course was gone. So justifiable to give another course. But yeah, within 1 or 2 weeks, probably there is no need to repeat another course. And as you
Yeah,
said,
I guess
sometime
it's, after second weeks, after 15 days, if
correct.
you are suspecting the pregnancy to happen in another 7 days, then you can go for one rescue dose.
Hmm.
But no repeating steroids every 7 days, which was
Correct.
there previously being practiced.
Correct. So this is, yeah, that should be avoided. Okay,
Yeah.
let's continue now. We have a lot to discuss.
Mother had PP-ROM and babies were delivered on 1st of December 2022 by LSCS at 31 plus 5 weeks gestational age. Single sterile vaginal examination was done and LSCS was undertaken after 4 hours of PP-ROM. Both the babies were male child. Birth weight of twin A, that is index case, was 1.36 kg and birth weight of twin B was 1.86 kg. Both the babies were AGA. Twin A cried immediately after birth. Cord was cut after 30 seconds and as a baby had no respiratory distress, routine care was given. Twin B cried immediately after birth. Cord was cut after 30 seconds and as baby had no respiratory distress, routine care was given. Birth weight of twin A was 1.36 kg, length was 41 and head circumference was 28 centimeter. Twin B weight was 1.86 kg, length was 43.5 centimeter and head circumference was 29.5 centimeter. In view of prematurity and low birth weight, both the babies were admitted in NICU for preterm care. In NICU, baby had no respiratory distress and was maintaining saturation on room air without any respiratory support. Total parenteral nutrition with minimal enteral feeding through infant feeding tube was started on day 1 of life. IV antibiotics was started after studying blood culture and IV caffeine was also started on day 1 of life.
Okay, can I stop you and have some questions on this before we move forward? You said both are AGA.
Yes,
So what could be the reason for such a big discrepancy? There's almost 500 grams difference in the two twins.
Yes, sir.
What could be the reason?
Sir, as we have done the CMV report also, and it was positive. So maybe CMV may have lead to the growth restriction of the baby. And
so what are the signs for CMV in this baby? So there was a growth restriction. There was some ventricular megaly. Any other signs were looked for? Any other test or any other viral markers were done? So looking at considering such a remarkable difference, because I presume there was no twin to twin or Dopplers were not abnormal, right?
no, Dopplers were normal and twin to twin transfusion syndrome was normal.
So what is the common presentation of CMV at birth?
A child with CMV would have rashes, petechia, then jaundice. Then at birth, the baby would be IUGR, SGA, IUGR baby, and baby would have ventriculomegaly, then periventricular calcifications. Then other findings would be late. That is sensory neural hearing loss and pneumonia would occur after some time.
Yes. So actually, most of the babies, around 80 to 85% of the newborns who are congenitally infected with CMV are asymptomatic. Only 10 to 15% of the patients would be symptomatic at birth. So now we know that our amniotic fluid CMV PCR was positive. So this baby is infected. But now we want to find out whether there is an organ involvement. So what Dr. Kiran wants to ask you that what would you look for in this baby as a marker of a CMV affection of the system? So what
yes, we can rule out hepatitis by doing aminotransferase levels, SGPT, SCOT. Then we can also do CBC to look for thrombocytopenia. And after that, we can go for confirmatory test, the urinary CMV PCR and blood PCR.
Okay, I also want to ask you at delivery whether the placenta was examined, whether the placenta was sent for histopathological examination.
No, placenta was not sent for histopathological examination.
Because now we had an amniotic fluid which was positive. We want to know whether the CMV has actually affected the baby or not. That would be very useful because the HP histopathological examination will give you the evidence of ileitis and all those things.
Yes, okay. Even placentomegaly and calcification in placenta would be there.
It was there in this baby?
No, it was not. Placenta was not examined.
No. Okay. Okay, fine.
So other thing I wanted to ask is the practice of two questions about practice of starting feeds. So whether both the feeds babies were started on minimal enteral or the bigger one was started on full feeds, and would you consider starting the babies on full feeds when they are 1.3 kilo and this weight? So what is the practice and any idea about recommendation of early enteral feedings, early full enteral feedings? So
No, we cannot. In this case, we had a weight discrepancy. So minimal enteral feed was started, and gradually it was increased.
okay.
And and in cases of a very low birth weight or such child, but if the Doppler is normal and everything is normal, then we can start with half feeds, half of the
So
total feeds.
have you is there a have you started some, what is your cutoff in the unit to start full feeds? Is it 32 weeks, 34 weeks, 30 weeks?
More than 33 weeks and more than 1.5 kg to start full feeds.
Okay. So this is something again a practice change, and I know there are centers who are starting 1.2 and even 31 weeks or 32 weeks definitely starting with full feeds. Some units are pushing lower, and the results are better. Even I mean, if you look at unit from Sushma Nangia and some of units in Mumbai also, they are pushing for this. But again, it is based on, and there are Indian studies on this, and the Western studies are still not enough. But I think there is enough Indian data to support that early enteral, full enteral feeding is beneficial for preventing sepsis, and you don't need lines, and
Yes.
the incidence of NEC is less. And one more thing is
Yes, sir.
what should cut off for starting routine caffeine? What guideline you follow? What gestation below which you start routine caffeine?
Yes, sir. We start below
So
33
next slide,
weeks of
yeah.
gestational age.
Right.
Caffeine.
Okay. So caffeine is good. I mean, I think everyone likes coffee. Caffeine is good for the babies, and there's good evidence for even late preterm to have caffeine. But I think general recommendation routine is 31 weeks and below 34 weeks. If they are symptomatic or distress or they have apneas, then only you start. So again, I don't know, AIMS protocol. There's always a discrepancy. Some protocols say 32, but by and large,
Yes, sir. They are written 32 weeks.
32. Yeah.
According to, I guess, CAP trial, our protocol is to start for less than 32 weeker with the routinely with the caffeine, and between 33 to 34, if there is a apnea,
Right.
then start with the caffeine.
So CAP trial was 21 years ago, but I mean, that was, I think it included 31 weeks, but it's okay. I don't remember. It could be 32. So as I said, it's good to start and good to be proactive, but just for discussion purposes, yeah, I think routinely all the babies, maybe at least 32 weeks and below, definitely should start caffeine. Okay, we can go further. Continue. Yeah.
Okay, sir. NICU course from day 1 to day 25 of life. Baby was vitally and hemodynamically stable. Antibiotics were omitted on 5th day of life after a negative blood culture report. Gavage feedings were gradually increased and baby reached full feeds on 6th day of life. Baby started gaining weight and was on spoon feeding from day 11th of life, and no any intervention was needed. As per the unit protocol, head ultrasound was done on day 1, day 3, and day 7 of life, which was suggestive of prominent lateral ventricles. From day 13th of life, baby had few episodes, 3 to 4 per day, of post-feeding desaturation. Desaturation levels up to 80 to 85% on room air, resolving on its own without bradycardia, for which antiemetics was started. This is the USG of the baby, suggestive of dilated ventricles. NICU course from 16th day of life. On
No
16th,
calcification, right? Was there any calcification or something?
no, sir, there were no calcifications on this.
Okay, continue.
NICU course from 16th day of life. On 16th day of life, baby had an episode of prolonged apnea requiring bag and mask ventilation with signs of shock. Temperature was 98.2, heart rate was 82 per minute, and saturation was 64%. CRT was 4 seconds, color was dusky, and pulses were poorly palpable. NIBP was 34, NIBP mean was 34 mmHg. So patient was supported with CPAP ventilation with PWP of 6 and FiO2 of 40%, but had persistent desaturation up to 80%. So FiO2 was increased to 100%, but still baby had persistent desaturation. Variation was from 80 to 85%. Within 30 minutes, in view of increasing oxygen need and respiratory distress, baby was intubated and kept on PTP plus TTP mode with following parameters. Maximum PIP was set at 30 and delivery, and it was delivering about 19 to 20. PWP was 6, respiratory rate were 40, FIT was 100. Targeted tidal volume was 8 liter per minute and I time was 0.36. CXR in ABG was done. CXR was suggestive of pulmonary plethora, and ABG was suggestive of hypoxemia, and oxygenation index was 31 at that time.
Okay, so what are your differentials right now? So very stable baby with some background CMV has deteriorated. We'll go to the echo later, but just on the history and this kind of a presentation, what differentials you were thinking?
Yes, sir. So the X-ray, from X-ray, we can say another differential would be HMD, but the presentation is very awkward because the baby was on room air and was stable and on 16th day of life. So HMD can be ruled out. And looking at such X-ray, we can go for any congenital heart defect or any congenital heart disease. And in that, there is a pulmonary plethora, so there is pulmonary congestion. So we can look for any obstructive left-sided heart disease. It may be aortic stenosis or coarctation of aorta, and also it may be any congenital cyanotic heart disease which may present later on. So these were the differentials.
Well, I think you gave many differentials. Let's go one by one. Now, if you're saying left-sided heart lesion, what is the typical presentation of left-sided heart lesion? Is it the pneumonia or is it something else? And what day of life typically it presents? I know the babies are preterm, they can present late, but what will be the typical presentation of the left-sided heart lesions?
Generally, it would present within 3 to 4 days of life, first 3 to 4 days of life.
So once the doctor then yeah, okay. But what is the presentation typical?
Cyanosis would appear.
Okay, so so typically, if left side is affected, if you have coact or hypoplastic left or something which you have missed in the initial examination, they'll present with shock. They may not have respiratory signs, right? They'll present typically with shock because it's a oxygen issue, forward flow issue, cardiac output is low. So anything like interrupted aortic arch, coarctation, aortic stenosis, left-sided hypoplastic left heart, all will present with shock-like symptoms, right? But this has plethora. So typically, what conditions plethora happens? If you're thinking this is plethora than pneumonia, which conditions plethora will happen?
Plethora.
So I'll help you out. So plethora means more blood going to the lungs, right? So what conditions lungs, more blood will go to the lungs?
So in PAH, plethora will be there. Then
which one? PH. So PH already, PH, the problem is pulmonary pressures are high. You are not able to oxygenate. So the pulmonary flow will be less, right? So PH, they get black lung. They don't get plethoric lungs, right? They get polygamy.
Polygamic lung pills, yes.
Right. So what causes more blood going to the lungs and less to the body? Okay, I'll help you out more. Which shunts will cause more blood going to the lungs?
Just a second, sir. Right to left shunting.
Right to left shunt will cause more. So when you say right to left, where is the blood flowing from? From where to where?
Blood is flowing from right side of the heart to left side of the heart.
The right side of the heart to the left side of the heart. So it is going towards the lungs or away from the lung? So it's going away, when you say right to left, so that means it's going from pulmonary side to the systemic side. So that means lungs should be not flooded, should be oligamic, right? So conditions which are ductal dependent and where the blood is going from the right side of the heart, that means pulmonary side, to the left side of the heart, which is aortic side, then you will not have plethora. So it's the opposite of that, right? So left to right shunts will cause plethora. So which are the left to right shunt which can present like this? And was there a murmur on the echo? I mean, sorry, on the examination? Hello? Kunjal, are you here? Are you there?
I think there's network issue.
Network issue. Let him come back. Dr. Kamna, after these 2 slides, I'll keep quiet and you can keep asking on.
No, that's fine, sir. That's
This is
okay.
my
It's
area
not
of interest, so I'm just pushing him a little hard.
I know. No, that's okay.
Okay, he's back with Dr.
Yeah.
Biraj. Yes, Munjal. So what I was saying, so which left to right shunt will present with plethora?
Hello, am I audible?
Yeah, you are audible. I'll repeat my question. So I'm
Okay.
suggesting that if you're thinking this is plethora, which left to right shunts can present like plethora, like this?
Left to
Okay, what are the left to right shunt in the body?
left to right. ASD, VSD shunts are left to right shunts.
And
PDA.
yeah. So was there a murmur suggestive of ASD or VSD or PDA?
No, no, sir. Not.
There was no murmur.
Yes, sir.
Okay. And do you think this presentation could be cyanotic heart disease or acyanotic heart disease?
Sir, it would be acyanotic heart disease because the manifestation is late and
correct. So in babies has saturations have been normal for some time, right? So like up to 16 days, baby sats were normal.
Yes, sir.
Still, is there any condition, cyanotic condition can present with normal saturation and after 2 weeks?
TOF maybe.
Okay, but again, TOF will have, so again, I'll put it in the context. So plethora, no cyanosis initially and then presented with little bit of cyanosis. Which condition can present like this?
Sir, can you repeat the question, please, sir?
So you have a plethora.
Yes, sir.
And stats were normal initially 15-16 days. And on day 16 presenting with cyanosis. So what could be the reason? Which particular condition can present like this? The TOF, we have pulmonary oligemia because there is a pulmonary stenosis. But there are pink TOFs. So you're right partially. You have to say pink TOF. So pink TOF, correct. You're right. So pink TOF can present like that. And then later on, when the pulmonary pressures are high, and then babies can develop cyanosis later on. So you're partially right. So that could be one answer. What could be other condition? You might have, I'm sure you might have thought of this during the presentation. Maybe Dr. Biraj can help.
Sorry, sir, I'm not aware.
So TAPVC can present like this, right? So TAPVC can have normal saturations, can have 92, 93 saturations initially. Baby was never in oxygen, so in room air. But later on, when the baby gets sick, babies can present with little bit of hypoxia, plethora, lung plethora like picture, right? So that is possible.
Yes, sir.
Okay. All right. So let's see. Let's look at the echo then.
Yeah, yes, sir.
Just a minute.
You're sharing the slides. Okay.
Yeah.
So
yeah, you may inquire and can have
again,
a discussion till the time I'll just get the
again, I mean, on the same context, when babies present with plethora, the typical presentation is low saturation, or is it tachypnea and heart failure? What is the typical presentation when you have more blood going to the lungs and lung plethora?
Yes.
Presentation.
The presentation would be cyanosis and tachypnea.
No, so when the blood is more going to the lungs, they saturate high, they saturate better, but they get tachypneic because of the flooding. They get tachypnea, distress, and they get failure-like symptoms. So they can get cardiomegaly, they can get little bit of hepatomegaly because of the fluid overload. But generally they saturate better. But very long-standing, this thing, they can develop some degree of pulmonary hypertension, and then they can have a bit of a drop in the saturation. So typically early they will saturate higher, and then they will be tachypneic. You know, they have suck rate, suck cycle, like signs of failure rather than
Okay.
signs. Okay.
Okay, sir.
Let's see. You can try and share your slides.
Yes, sir. I'm trying.
So I can see there's an echo coming. So I would like to see what's there in the echo.
Is it visible now?
Yes, yes. Okay. So let's go to the echo.
Probably work नहीं कर रहा है. Try, yeah, it would.
Is the video playing?
Mm.
Yeah, but I can appreciate certain things. So go back and yeah, you can read the findings.
Yes, sir. In view of increasing ventilator need, baby was shifted to HFO ventilator, and at that time, just a second, sir. HFO ventilator with MAP of 15, which was later increased to 19 with FiO2 of 100% and frequency 12. At that time, saturation was 80%. Inhaled nitric oxide was started at 20 ppm, after which saturation increased to 85%. So INO was later increased to 40 ppm.
So what were the echo findings? I can see certain things.
Yes, sir. We can see the 4 chambers of the heart. The right side of the heart appears little dilated, and in the on placing the Doppler, it was seen, TR jet was seen.
Do you know how much was the TR?
It was around 52.
Okay. So almost moderate systemic or suprasystemic pulmonary hypertension. So well baby who suddenly deteriorated, and then there is a RA-RV dilatation, and then there is a TR which has caused this baby to flip into pulmonary hypertension. So now what are your differentials? Why the baby should develop sudden pulmonary hypertension? Or do you think there was a pulmonary hypertension was there and baby is manifested now?
Sorry, sir. Can you repeat the question?
So my question is, so now what are your differentials? So you have a plethoric sort of looking lungs, or like, you know, whiteout kind of thing. And then you have a pulmonary hypertension, moderate with some ventricular dilatation in a very well baby initially. Like baby was stable, right? And then sudden deterioration. So what are the differential right now? Initially we discussed about based on the X-ray. Now on echo, what are your differentials? So what causes pulmonary hypertension? Do you think the pulmonary hypertension was there since birth, or do you think baby has developed right now?
No, baby may have developed right now.
Because of?
Because initially the saturation levels were normal, and blood pressure was also normal at the time of birth.
So what could be the reason of baby flipping into moderate pulmonary hypertension, moderate to severe pulmonary hypertension?
Maybe the patient may have, because the patient had CMV infection, maybe may have CMV pneumonitis, and it may have lead to PH.
Right. So pneumonia is possible. So any kind of pneumonia, viral pneumonia, CMV likely in this case, or bacterial pneumonia leading to sepsis and then flipping into pulmonary hypertension possible. Anything else?
Any other, sir? Cardiac causes and extra cardiac causes like vein of Galen malformation that may have done. And
correct. So yeah, you're right. So sometimes AV fistulas, vein of Galen malformation, something can present with this kind of a picture, like baby looking fine and then developed sort of pulmonary hypertension, plethora, and high output cardiac failure. That's possible. So was that ruled out in the ultrasound of the head and everything?
Yes, HUS was done and it was not
It
suggested.
was not there, correct. On the first scan, it was not there. And one more question about the is there evidence to give nitric at 40 ppm? Any trials you are aware of? Any particular reason to go to 40 and not 20?
No, sir. We searched some trials, but there is not any documentation that it should be increased to 40 or it should be started at 40. But the patient was responding at higher INO concentration, so we increased to 40.
Okay, okay. So kind of out of desperation, sometimes you tend to go up. You want to throw everything, and it's very unexpected presentation. So that's fair enough. What is the concern of giving high dose of nitric oxide?
Methemoglobinemia and thrombocytopenia may occur after INO treatment.
Right. So do you routinely monitor for methemoglobin in your lab?
No, sir. We do not monitor at our institute for methemoglobinemia.
So many of the gas machine actually do give methemoglobin value. So maybe, it could be just talking to the lab people and talking to the company guys to add this methemoglobin parameter also on it, because it does detect actually. So it's always good to start before starting the nitric and even after giving. So in fact, I have seen methemoglobin even at 10 or 15 ppms, and babies can get, cyanotic because of that. So that's something is a worry. So earliest opportunity when you start 40 and baby responded, you should come down to lower dose. And ideally is to start at 20 and then go down to 15 or 10. The general protocol is 20, from 20 to 10, 5, and then 5, 4, 3, 2, 1.
Yes,
And based on the saturation and FiO2 requirement, the FiO2 requirement below 60 and all those things. Anyway, we can discuss that. So go further and continue the case, and then we can ask.
Can I stop you before you go ahead?
Yes, yes.
So if you would not have known that the amniotic fluid PCR is positive, would you have thought about CMV in this patient? Like we usually do not do the TOT screening of all the mothers. Now, no international guidelines suggest to do the TOT screening of patients. But gynecologists, most of the gynecologists do it, arguing that the benefit of negative report will be that the mother can be guided to not gain a new infection by strict hygiene measures and all that. So usually the torch titers are not done for all the pregnant women, right? Yes, so you would not have known this CMV PCR report. Do you expect this to happen in a CMV, congenital CMV patient? What kind of a cardiac manifestations do you see?
Cardiac manifestations of CMV.
Yeah.
Aortic arch anomalies are present due to CMV, and
aortic dilatation is usually commonly observed in the CMV. Yes, VSDs are observed, cardiomyopathy has been observed, but usually whenever there is a CNS involvement, it is rarely associated with the cardiac involvement. Okay, go ahead.
Invasive BP was 38 by 26 mmHg with mean being 30 mmHg. So inotropic support was started with noradrenaline at 0.05 microgram per kg per minute, which was increased to 0.2 microgram per kg per minute. Still, the baby had hypotension with mean BP being 32 mmHg. So injection adrenaline was added at 0.05 microgram per kg per minute, which was then increased to 0.15 microgram per kg per minute. Gradually, blood pressure started improving. IV milrinol and IV fentanyl continuous infusion was started. After all these interventions, saturation gradually increased to 92%. Baby was kept NBM and TPN was started with antibiotics after sending blood culture. Repeat CXR and ABG after 12 hours were done. X-ray and ABG both showed improvement with PO2 levels of 106 and oxygenation index decreased to 16.9 from 30. And invasive BP was suggestive of 52 by 36 mmHg with map of 41 mmHg. On day 19, urinary CMV PCR and blood CMV PCR were suggestive of more than 10 million copies and 97,000 copies respectively. Repeat SGPT was done, which was 78. Earlier, it was only 8. IV ganciclovir was started. Inhaled nitric oxide and ventilator settings were gradually weaned, and baby was off inhaled nitric oxide by day 3 of illness, that is day 19 of life, and off ventilator on day 5, that is day 21 of life. Baby was further supported with CPAP on day 6 of illness, that is day 22 of life, and was on room air on day 23 of life. IV milrinone was given for 2 days, after which it was tapered and omitted, and IV sildenafil was started. Inotropic support was weaned gradually, and Gavage screening was started on 23rd day of life. CMV screening of twin B was also done, which was negative.
Any opthal examination was done in this child?
ROP was done, yes, ma'am. After stabilization, after 1 week, ROP was done for chorioretinitis, but it was normal.
It was normal. Okay. And you have a transaminitis. Sorry, go ahead, Dr. Kiran.
I was just asking, hearing, I mean, it's too early, the babies are preterm, but
Yeah, the screening would become
for the hearing. Yeah.
correct. So there is a transaminitis. There is query hemodynamic instability because of this cardiac cause, and there is a bilateral ventricular dilatation. So would you contribute all this to CMV?
Yes, it may have contributed to developing such disease. CMV may have contributed.
Correct. So what is the cutoff for this quantitative PCR to consider it to be, we should be treating it? Like, I mean to ask that when we get so many PCRs positive for CMV, do we treat all of them?
If the babies are asymptomatic, then we don't treat. But if there are any symptoms like transaminitis or any other symptoms, then we treat the babies.
Correct. So only symptomatic newborns should be treated. They are labeled as a congenital CMV infection. This PCR was sent on day 19. Okay.
Yes,
so till
21 days, if the report comes positive within 21 days of life, then it is considered as congenital, or else it is considered as postnatally acquired CMV infection.
Yes, nosocomial. If they are staying in ICU for a long time, it's called as a nosocomial CMV infection. Okay. So the drug of choice is ganciclovir. Started at what dose?
6 milligram per kg per dose, twice a day for 1.5 months.
So you give IV for 6 weeks?
Yes, ma'am.
Okay. That was done for this baby, or you think this is the protocol?
This is the protocol, and then if there is improvement, we can shift to oral valganciclovir.
Yeah, so IV is given till there is a clinical improvement. So in most of the children, we achieve a clinical improvement in 2 weeks of time. Yes, and after that, the patient is shifted on oral valganciclovir. What monitoring should you do when the child is on ganciclovir?
Yes, ganciclovir causes neutropenia. So bi-weekly CBC should be done up to 1 month, or up to IV administration of antibiotic, and then once in a month should be done. And
it also causes
also the liver enzymes should be checked.
Yes, so it also causes a hepatotoxicity. So RFT, LFT, and CBC should be repeated every weekly.
Yes,
right. Will you do a repeat quantitative titers in this baby? To see the response to ganciclovir?
Yes, but in guidelines we have not. I have seen that it should be done, but we can repeat after 1 month of administration of valganciclovir to check whether the medications are sensitive to it or not.
Right. So actually, we do not usually do the repeat quantitative titers if the baby is improving. If the baby is not improving, then we do the titer, because we have observed the ganciclovir resistant in the CMV. And the alternative drugs, if there is a ganciclovir non-response in clinical scenarios, are foscarnet and cidofovir. Yes. Correct. So we have come across ganciclovir resistance not in a congenital CMV, but a CMV in a transplant associated settings where we are already giving a prophylaxis for long duration post solid organ transplant as well as post BMT. That time we are already giving a prophylactic ganciclovir. In those patients, we have observed the ganciclovir resistance, and we had had situations where we had to use the alternative antivirals in these patients.
Yes, ma'am.
Okay. Anything you want to ask, Dr. Kiran?
Yeah, no, I think the, question was whether we could have screened and picked up this soon after birth rather than developing the signs, but it would have been a dilemma to treat at that time, right? Because baby was so well. So after presenting the pneumonitis, probably, I think the decision to treat became more
I'm not sure whether there was a pneumonitis. Any
yeah,
mini-ball samples would have been ideal specimen to send for a CMV PCR if the child was intubated at that time. That in that duration we would have done that. But otherwise, also very high viral load on a urinary PCR, and with this organ involvement, it's justified to treat him fully with the CMV.
Ma'am, which sample did you say that I?
Ball samples.
Sorry?
Mini ball samples.
Okay.
It's a ball sample. It's called
Lavage.
as a mini ball. Yeah, bronchoalveolar lavage. When the child is intubated, through the endotracheal tube itself, you push little saline and suck it out, and that samples. They are lower respiratory secretions basically. So it's called as a mini ball. You do not need to do a bronchoscopy to achieve to get the sample, but
Okay.
you do it in the ICU itself. A mini ball sample.
Okay, ma'am.
If you want to prove the pneumonia due to CMV, that would have been an ideal specimen to send for the PCR.
Okay.
great. So, some questions we can ask about pulmonary hypertension. So, what do you think, should be the first line of treatment in the pulmonary hypertension? You did, I think, correct here in this case, but in generally, suppose somebody deteriorating and presenting pulmonary hypertension, what are the things, what should be your, what's your approach to manage such babies?
Yes, sir. In such cases, IV milrinone should be started because it improves the pulmonary vascular resistance and decreases the pulmonary vascular resistance. And also, in case of left ventricular dysfunction, it also helps by positive inotropic and chronotropic effects. And another option is we can go with dobutamine. But dobutamine.
What is the concern with the pulmonary milrinone as first line? So I'm getting these answers quite repeatedly, even in my unit, also even some of the recommendations. So first of all, where is the evidence? Strong evidence that it causes pulmonary vasodilatation. It's a lysotropic agent. Where is the evidence that it will cause pulmonary vasodilatation? And what is the major concern with pulmonary? So your pulmonary pressures were 55, 60. And if you start milrinone as first line, what is the concern?
Systemic hypotension.
And then what will happen?
Systemic hypotension would cause decrease preload.
Okay. So it will cause more. So it will worsen the right to left shunting, right? You have a sick baby, SATs of 60 to 70. If you start milrinone at that time as a first line, there's a chance that baby might develop hypertension and then might get worse actually. So what is better drug?
We can go for INO and sildenafil because both have similar action. Both act on both act by cyclic AMP and CGMP and act at the smooth muscles and causes dilatation of the arteries, pulmonary arteries.
Correct. So amongst the two, which one will be better?
INO would be better because it is a potent pulmonary vasodilator, and we can supplement it with sildenafil.
Correct, and it's basically acting directly on the lungs, those systemic side effects, right? So the idea of managing pulmonary hypertension is, firstly, you did all the things right. Baby was ventilated. Then first thing you do is recruit the lungs. It could be just that lungs had collapsed and the pneumonia has developed, or there's a plethora and there was a pure oxygenation failure. You had a very low PO2. SATs have dropped. So you have recruited the lungs by putting the baby on high frequency. So first thing you optimize that. With that, suppose if there is no response, second thing you do is you try to decrease the pulmonary pressure. So best drug is actually nitric oxide. It is questionable. This baby was late preterm, also late presentation, not very typical PPHN. So sometimes they may not respond, but it's always worth trying. So almost 25-30% of the babies may not respond with inhaled nitric oxide. But in such situation, when you are desperate, you can try. And I think you got a response to nitric oxide. Sildenafil, which route you will give, oral or IV?
IV, but studies have mentioned that both are potent ways, and there is not much significant difference.
Right. But what is again concern with IV? Suppose we start IV sildenafil, what could be other issue?
Again, systemic hypertension would occur with IV sildenafil.
Correct. So that's another problem, right? So if you give sildenafil, you can have a systemic hypertension. So you are getting some pulmonary vasodilatation, but suppose systemic hypertension is more, you might have more decrease in the right to left, more increased right to left shunting, and maybe will be still hypoxic. So that's why nitric oxide works better than sildenafil. But what you can do is you can optimize the blood pressure more, and then try to get the sildenafil on board, so that you have a decreased right to left shunting. What is concerned with dobutamine? How dobutamine you said is the third choice, right?
Yes, sir.
I'm refuting melrinone and sildenafil. Now dobutamine. How it will help? What's the mechanism of action?
Yes, sir. Dobita, it will act on the alpha receptors. It is a pulmonary vasodilator and systemic, also systemic vasodilator. So
it's a systemic vasodilator. Pulmonary vasodilator, I don't know. I have not yet to read whether it dilates pulmonary vessels, but maybe there is some evidence. But because it acts on alpha 1 and beta 2 receptors.
alpha receptors, yes, sir.
There are no receptors. I mean, in pulmonary, well, it can technically, but there is no action specifically mentioned for. So people started to support the heart. So it's not completely wrong. So because you have a RV dilatation in this case, right? So your melrinone or dobutamine can be justified because your right ventricle is under pressure. You want to support the heart. So only action with dobutamine will help is you support the heart. So you improve the right ventricular contraction, left ventricular contraction, and improve the forward flow. But as you rightly mentioned, there could be systemic vasodilatation. So again, same concern. Sometimes they get hypotension after dobutamine, and again, right to left shunting can be worsened. So it's always, I always say, don't go by my choices first, second, third. Go by echo, what you want to do, optimize. In this case, you wanted to recruit the lung and give nitric oxide. Baby responded, then I would wait. The function looked okay in this case. Then I will try to get the blood pressure up. There was a possibility it could be viral or bacterial pneumonia. If baby is flipping into sepsis, probably some, and the function is good, you can start with nor-AP as well, because then you can get the blood pressure up. Sometimes people start vaso, but vaso probably is a second or third line because it's a potent vasoconstrictor. It will get the blood pressure, systemic blood pressure up, and again some theoretical effect on pulmonary vasodilatation. So I'm just throwing a lot of drugs, but basically idea is to choose the drug and understand its effect, and then titrate according to the clinical response. And then obviously I think you did right thing. So babies did respond. I could see that baby improved, and then the next X-ray, the heart looked very small. So MAP was higher. So probably, baby responded within a day or two, and then you have to back off and improve it further. So what is this bovine aortic arch?
Actually, sir, I read it, and it is seen that it is a common variant, and it is found in 20 to 30% of the human beings. In that, the one of the artery directly comes from the trunk of the brachiocephalic trunk. From the right side, one of the right-sided artery comes from the brachiocephalic trunk. So that is bovine aortic.
So yeah, it's a normal variation as you said, but can it give trouble sometime?
Sir, that I'm not aware of.
Very rarely, sometimes vascular clink kind of thing can happen. The way they're emerging, and if they're compressing on something, it can present. Otherwise, most of the time it is just like an autopsy or incidental finding. They don't generally by and large cause, and they shouldn't cause pulmonary hypertension also.
Yes,
so I think that's it from my side. I think Dr. Kamna, if you want to discuss and enlighten us more on CMV, because I think this is always a issue, to treat or not to treat. That dilemma is always there for CMV. Despite clear guidelines, two system involvement, and it's always, I think, for every clinician, it's always a challenge. Maybe you can enlighten us on something on that.
Yeah, so as you said, the clinical dilemma is always there because the CMV is done for some reason. We did not expect it to come, but the titers are around 20-30,000 copies per ml. These kinds of reports, we should always see whether the child is symptomatic or not. One. Second, if there is a the child is symptomatic due to CMV, that means there has to be some organ involvement. So most commonly, it's a CNS involvement which we see. The most other common presentation is CMV pneumonitis. The third common presentation, I think, is HS megaly, petechiae, thrombocytopenia, the typical. So I think if none of them is present and if there is only sensory neural hearing loss, which is on the follow-ups. There are many trials which are done that ganciclovir does not affect the outcome and that does not require warranted treatment. These children actually require a follow-up till 4 years of life, the hearing assessment and neurodevelopmental follow-up every few weeks. That's it. I think they want us to finish now.
Perfect. Yeah, I think
Yeah.
we had a discussion. So well done. I think a good presentation.
Yeah,
The team, Anand. Any questions from any audience or anyone else, or the presenter has any question? Over to you, Prashant. I think we are done.
Yeah, thank you. Thank you so much, Dr. Prashant, Dr. Viraj, Dr. Kiran, to give us an opportunity. Thank you.
Thank you. Thank you, everyone.
Yeah, it was really a wonderful discussion. I mean, the case was going very fine. I just reminded that we are about to end. But then thank you so much on behalf of NNF Gujarat. I, Dr. Prashant Karya, thank Dr. Kiran More, Dr. Kamna Gandhi, as well as result also. So thank you so much. And we'll be meeting in all neonatal pathshalas by following the same ClearNet link. Those who are on the ClearNet platform, you are to register only once. Once you register, you'll be able to log in to the same platform every Wednesday at 3:30 p.m. And those who are on YouTube can watch to all the speakers, experts, as well as Munjal. Over to yeah. Thank you. I think he's not able to unmute. So, Sagnik, we can end the meeting now. Thank you so much. All the experts. Sorry, actually,
Sir,
we're supposed to send you the certificates. Yeah.
so we have
Yeah.
the certificates with us.
Yeah,
I can
yeah,
share
that's
them
what I
right
said.
now on the screen. Right?
Sure. Yeah.
Okay, sir.
Thank you. Thank you very much.
Is it coming full
So
screen?
on behalf of NNF Gujarat, yeah, it's coming full screen.
Okay, okay, sir. Okay, sir.
Thank you, Dr. Kamna Gandhi, for being expert in neonatal Pathshala.
Thank
The
you.
same is presented to Dr. Kiran More. Next, please. Sagnik.
That's very impressive. The fastest I've got a certificate ever.
No, Kiran, we have sent you last time also, last year.
I remember now. Yes. Yes.
Yeah.
Thank you. Okay.
So, thank you so much. And the certificate of appreciation is presented to. Thank you so much.
Thank you.
Thank you.
We can
Bye.
end the meet now. Yeah.
Yeah. Thank you, everyone. Thank you.
Bye-bye.